Oki Sani Tapi Mitaniku Namo Siaoki Namo Tutu Skapi Pikuni. Hello, everyone, and thank you for joining this community of learning titled Expanding Maternal Health Services at Urban Indian Organizations. My name is Maddie Curry, and I am a member of the Black 8 Nation and also a public health program manager at the National Council of Urban Indian Health, also known as NCUIH. I will also be your host for today. And joining me from the NCUIH team are Aaliyah Smith-Gomez, our project coordinator, and Amy Lord, our comms associate. And we are honored to have you all here today. Thank you for joining us. We kindly ask that you place your name, organization, tribal affiliation, and job title in the chat box. In addition, we welcome any feedback you'd like to provide about your webinar experience in our feedback survey, which will be posted in the chat box as well. Next slide. So just for housekeeping, as we dive into our session, here's a couple things to keep in mind. This session is being recorded. All of your mics have been muted. Your questions can be typed in the chat box if you have any, and then we will have a nice long Q&A session at the end of this session for all of your questions. Next slide. So as you can see on the agenda, our presenter will provide a detailed presentation on the development of their full spectrum OBGYN clinic at the Oklahoma City Indian Clinic. And we will end the session again with Q&A, survey reminders, and upcoming opportunities at NCUIH. Next slide. So just to provide a little background on us, the National Council of Urban Indian Health, NCUIH, is a national representative advocating for the 41 urban Indian organizations contracting with the Indian Health Service under the Indian Healthcare Improvement Act. NCUIH strives to improve the health of the over 70% of the American Indian and Alaska Native population that lives in urban areas, supported by quality healthcare centers. Next slide. We also want to take a moment to recognize that addressing maternal and child health in Native communities is an extremely sensitive topic that might affect some participants today more than others. If you find yourself impacted by today's discussion, please do not hesitate to connect with your support networks or reach out to NCUIH, and we can provide you with some healing resources. Next slide. All right, so now I'll introduce our wonderful presenter. Dr. Tyler Freeman is a family practice physician in the state of Oklahoma. He graduated from the Oklahoma College of Medicine and completed residency at the Great Plains Family Medicine with the Integris Baptist Medical Center. Dr. Freeman is currently the Director of Family Practice and Specialty Services at the Oklahoma City Indian Clinic. In addition to his leadership role, he oversees the clinic's women's health program on the PINK team, which includes full spectrum obstetrics, pediatrics, and gynecology care. The PINK team also helps train young clinicians, including residents and medical students, through partnerships with academic programs throughout the state of Oklahoma. Again, there should be an ample amount of time at the end of this session for questions and answers with Dr. Freeman. As he's going through this presentation, we encourage you to think about questions to ask about applying this work to your UIO. And now we will turn it over to Dr. Freeman for his presentation. Dr. Freeman, you have the floor. Next slide.
Okay, well, hello, everyone. I appreciate the opportunity to get to talk a little bit about how women's health has evolved for us at the Oklahoma City Indian Clinic, sort of what the milestones were for us, both from the origins of our clinic all the way up until we sort of recognized the need for an expanded service line and how we were able to accomplish that. Hopefully, I'll be able to give you some peace of mind if you're looking to improve the service lines at your own clinics, maybe give you a lifeline or a resource if there's specific questions or concerns that you have. But definitely just trying to kind of explore some of the things that we had to navigate as we grew to where we are today and as we look forward at our future planning. So next slide, please. So who are we at the Oklahoma City Indian Clinic? We were founded in 1969. It was a group of volunteer physicians. They incorporated by 74. It was sort of a much smaller, limited urban clinic in that capacity, but it has grown substantially since then. We're currently working out of four full facilities at this point. The original building, which is what I'm in now of our current campus, 2 additional 3-story buildings kind of catty corner from here, a resource center next door to this main building that houses a lot of our social and support services, as well as a new building, which we are currently renovating for an expansion of our services in the future. We are an urban Indian health clinic, just like many of you are, as I understand. So we kind of operate under the same sort of billing circumstances, funding, our expectations, patient models, and all of those things that hopefully in some ways is very similar to where you are, so that you can sort of see how we were able to grow and apply that for yourself. Next slide. So overall, like I said, I kind of want to look at a timeline just to sort of give you an idea of where our women's health program was when we decided to sort of make that jump to significantly increasing the services that we offered here. I think it's important to sort of recognize where you at in that timeline as you begin to sort of develop what your next steps are going to be. And so hopefully, as I sort of explore what our path looked like, you can see yourself somewhere in this process and understand kind of what questions might be most relevant for you, or hopefully you'll see you're further along than you thought you were, and you'll be able to kind of change those processes going forward. Next slide. So in the beginning of kind of the growth of what became what is now our women's health program, essentially primary care was the main setting where our women's health services were completed. Like I said, our clinic started from a very small perspective with volunteer physicians, grew pretty substantially over those first couple decades, but women's health as a separate service line did not start to develop until about 2015. So our primary care physicians, which is I'm sure the model that many of you are using now, oversaw our women's health as part of the overall kind of medical care that they were providing to Native Americans in the urban kind of Oklahoma City and metro area here. That meant that they were the ones that were completing PAPs or referring women out if they had abnormal PAPs, counseling about breast cancer screening and the resources that they might be able to find here in Oklahoma City. And also in a limited capacity doing some early prenatal care. For the most part, those patients had to be referred out. You know, that was not a service that many of our providers felt very comfortable with, and especially early second trimester, everyone had to be referred out, which for our uninsured patients was difficult. The nearest facility to where we are now, about an hour and a half away, which, as many of you know, our patients don't always have consistent access to transportation, funds to get there, or the ability to take off time from work to make trips like that. So we recognized around 2015 that we needed to make a change. Next slide, please. So that was when we sort of made the decision to hire a dedicated nurse practitioner who is going to oversee the women's health program. Next slide. So she was hired to kind of separate out some of the aspects of women's health for our clinic. And I think that was a very important stepping stone. So if you're looking at your own internal women's health processes and sort of thinking about a timeline of wanting to expand and see your women's health sort of quality metrics and services grow, I think the first place is to really identify women's health as a subset of medicine that you need to dedicate some time and attention to. Women's health, there are several issues that are unique to women, not just pregnancy. There's a lot of preventative screening that is unique to women, both related to the postmenopausal state, their cancer risk, but obviously also contraception and prenatal care. But once we hired on a nurse practitioner, they were able to, number one, dedicate a full schedule to these women's health issues, but also sort of gave a voice to champion a women's health program at our clinic. As many of you know, women's health issues are often not at the forefront of research, medical decision-making in a lot of capacities, both in the community clinics, but also within Indian health. Sometimes those things just sort of fall behind. So having someone dedicated to champion those issues was one of the most important early steps for how our clinic was able to grow and improve. With her addition, you know, a focused cervical cancer screening program, including PAPs, looking at DEXA screening and ruling out kind of bone density for women either at risk or postmenopausal, and then a dedicated sort of doubling down on emphasizing breast health and receiving screening mammograms within the community. Also, by getting a nurse practitioner who was trained in women's health, we were able to increase our prenatal services up through about 24 weeks, kind of the very end of that second trimester, where the delivery planning and some of those other more complex issues in pregnancy started to come up. That was the stopping point of our prenatal care at that time. So next slide. The next thing that we sort of added while that nurse practitioner was still here, and this was kind of in that transition period where I had agreed to come and join the clinic, but I hadn't quite gotten here yet. We started to talk about some of the service lines that I really wanted to see grow. And one of those from a GYN perspective was colposcopy. Colposcopy, for those of you who are not aware, it's the follow-up step after a screening pap smear is abnormal. Essentially, we're able to look at the cervix under a microscope and identify areas that look atypical or abnormal and take biopsies specifically to rule out precancers, hopefully not a true cancer, but sometimes those diagnoses are made as well. And based on those results can kind of hopefully give a woman peace of mind. Hey, we biopsied, there's not a true atypical cell here. But in some instances, recognizing we need to go to the follow-up step, which would be a diagnostic excisional procedure like a LEEP or a cold knife cone biopsy, or in a worst case scenario, a hysterectomy for a woman who may have a more aggressive cervical cancer that was caught at a later stage. Next slide, please. So as the nurse practitioner began to sort of develop and evolve that clinic, simply adding the ability to do colposcopy in-house dramatically changed our outcomes data and the frequency with which women completed that follow-up screening. Again, a 90-minute drive from here is what it took for a woman to have access to services like colposcopy. So again, when you don't have a regular functioning car, you can't afford the gas money, you can't take off time from work to get there, some women just didn't make it a priority. And as we all know, cervical cancer, very, very preventable, very easy to catch early when we're sticking to that screening regimen. But for some women, they would just come back in a year or two and get another PAP, which sometimes is okay when the body's able to clear things up. But when it wasn't, women were being caught with more advanced stage cancers or definitely higher grade dysplasia that limited their treatment options. So by doing colposcopy in-house, I feel like that's a very significant game changer that really any system, wherever you're at in sort of the size and scope of your urban clinic, colposcopy is something that you can find one of your providers to feel confident in and to get trained in. IHS offers training for this. There's several community centers around where we are, but if you're anywhere near an academic center or have the capacity to send one of your providers there for training, there's a bit of a learning curve, but once they get started, I think this is something you're going to see pay dividends down the road for your clinic. And that's certainly what we saw here as well. Next slide, please. So the next kind of big benchmark is where I feel like our growth began to change pretty exponentially. And that was when our clinic hired our first physician dedicated to women's health. So that was the opportunity that I had to come and join the Oklahoma City Indian Clinic. And so that was 2019 going into 2020. I joined the clinic here. This, if you'll go to the next slide, gave us an opportunity to basically expand our women's health coverage almost completely as far as our outpatient setting is concerned. So prenatal care went all the way out to term, including offering delivery options for some of our women. And by offering full-term prenatal care, that's a big deal for a lot of our Native women. They want to stay within Indian health. They want to be able to stay within the community where they live. And even for those who are insured, they want to stay with a doctor who can provide them with culturally competent care. And that was something that we were able to offer once we started to expand our service here. We don't have a standalone hospital. This is a clinic. It's not an Indian hospital. But we were able to partner with community hospitals. As you may have heard in my bio, I completed my residency with Integris. So I had already worked within that system, even being a family practitioner, but trained in obstetrics. I had a good rapport with those providers there in that system and had already kind of told them in advance, hey, this is something that I want to build in Oklahoma City. It's a partnership I want to see grow. And that, I think, is a very important aspect of making this jump from the outpatient services that a nurse practitioner or a dedicated, physician might be able to accomplish, up to that next step of offering full prenatal care and expanded women's health services. You have to be able to kind of flex some partnerships to do things like that. And you have to have a physician who's willing to really put in the work to make those relationships stick. Delivery options, for our patients, it's not every woman who comes through our clinic that's pregnant that gets to deliver with our team, because again, we don't have a facility for delivery here. So for our uninsured patients, those women still ultimately have to be referred out to the Chickasaw Nation or Claremore Indian Hospital, which are the two closest facilities to us. And even some of our privately insured women, when they look at their copay options, realize financially it's more responsible for them to go ahead and deliver at one of those facilities as well. But many of our private pay patients, and certainly all of our patients who are eligible for Medicaid, which is the lion's share of the women who come through our clinic, they're all eligible to deliver with me. And later on, as you'll see in our timeline, one of my partners who joined us at Integris, which is the community hospital we partnered with. That certainly took some legwork to get established. Like I said, it really helped that I had trained within a facility, that the obstetricians there knew me, especially being a family doc, kind of getting your foot in the door for full practice or full spectrum obstetrics can be a challenge, I think, for a doc coming from an outside community to a new center. But I think, especially for us at the Oklahoma City Indian Clinic, having a family doc champion women's health from this perspective made the most sense, just from a volume perspective, the ability to lead to improved outcomes for our newborn care and retaining those pediatric patients, and also financially. I think it's just, when you look at the sustainability of your growth, other than in certain circumstances where you may have a dedicated OBGYN provider who's willing to kind of significantly reduce their early volume, for the most part, a family doc, I think, made the most sense for us and may mean the same for you. It also meant, as a solo provider at the beginning of a new practice, I was essentially on call by myself for 2 years. So that, again, it's not for the faint of heart. You're definitely going to have to find a physician who is excited and motivated to impact change in your clinic and dedicated to seeing women's health outcomes improve. That was the case for me. It may not be the case for everyone that you might recruit to your clinic. So I think you have to be really upfront with yourselves and with those providers about what the time commitment is going to be, what the expectations may be for you to see that clinic succeed. But if you can find the right fit, if you can kind of flex those relationships with community partners, it pays dividends. And like I said, this was kind of the turning point where we really saw our women's health services improve exponentially. Next slide, please. So over that sort of 2019 up to 2021, going into 2022, like I said, there was about 2 years that I was a solo provider for an OBGYN program. Prenatal care, as some of you may know, does not really follow a schedule. I actually have a patient in labor now, and despite having a partner, she's actually on vacation. So kind of one of those, hopefully she doesn't deliver during the presentation sort of moments, but that's kind of how OB works. And so especially when you are a solo provider, that can cut into your evenings and weekends and your ability to see patients in clinic. There's a lot of moving parts that you have to navigate to be successful when it comes to being solo. Fortunately, we were able to kind of tread that water and really see our clinic program grow pretty substantially here, to a point that it was financially feasible and responsible for us to add a second provider. And if you go to the next slide, by adding a second physician, first of all, it dramatically improved my sort of quality of life and workload. We still, at this point, are 12 days on, 2 days off. So every other weekend we're off, which many providers, especially those who are used to a purely outpatient schedule, would still say you're on all day and all night for 12 days in a row. But when you come from 2 years of being on call forever, every other weekend is a tremendous improvement for me. And I'm sure that whoever you have kind of start your program will recognize that as well. But by hiring a second MD, it helped us to improve the ability to provide services, not only for that work-life balance, but within the clinic as well. When you've got a solo provider, if I have to leave to go do a delivery, or I have to go be involved in another sort of significant issue related to women's health, my clinic sort of comes to a stop. And that is a significant aspect of recognizing how you develop and grow a women's health program going forward. And it was at that time that we also recognized, with the growth of our women's clinic, we needed to have a dedicated sort of team manager, which we identified as an RN, to help coordinate care, to help follow up on those expanded service lines that we were offering, but also just to kind of help us coordinate our time and our energy as we focused on accomplishing new goals going forward. So again, adding that second MD, there was a lot of time and work that had to go into building a program for that to be a responsible decision. But once women started to hear, hey, you can go get prenatal care at the Oklahoma City Indian Clinic, you can go all the way out to delivery. One of the docs from the clinic can deliver you at a private hospital. As I'm sure all of you know, word of mouth is probably the most important thing in Indian country, and word spread fast. I had women who were transferring from private docs in the community to come and see us here because they're like, I didn't realize this was here. I want to deliver with the Indian Clinic. I want my kids to come here. Your program will grow. You'll be surprised how excited and empowered your Native women will feel when they realize, hey, my health is being made a priority at the clinic. And again, as a family doc, getting to take care of those women, getting to take care of the kiddos after delivery, and continue to see those moms even in the postpartum stage. Women drive healthcare. You know, if that's not something that you've recognized already, let me just tell you now, moms, aunties, you know, partners, those are the people who, hey, you need to go to the doctor. You need to go in and get your checkup done. They're the ones who bring the kids in most consistently. They usually have the ear of everybody in the family to kind of help guide some of that decision making. So not only pregnancy, but the whole family, we saw improved outcomes by focusing our time and energy on these women's services. And that, I think, was clearly proven by our ability to add a second MD successfully. Next slide, please. So from there, as we sort of grew the capacity of our clinic, the number of visits that we were able to dedicate time to for women's health specific issues, and especially as our prenatal program continued to grow, sort of adding volume from year to year, the next thing that we wanted to focus on was taking a step back and looking at the GYN perspective of our women's health services. So we had built out a kind of robust cervical cancer screening program. We have followed that up with colposcopy, had been much more successful at tracking those outcomes and getting patients sent off for diagnostic procedures. But we wanted to do a better job of identifying women who were at risk for cancer in general. And so that led to us really pursuing an opportunity for genetic hereditary cancer screening. Again, this was a partnership that we had to explore with several groups. We had to kind of identify what worked well for us. But if you go to the next slide, we were able to find a partner with Myriad Genetics that gave us the opportunity to add this service line within our clinic without a financial burden from us, and significantly improved our outcomes. We essentially built out a screening protocol from when a woman walked in the door. She was asked several questions on that kind of initial screener that we used through registration. The women who screened positive were then given a more advanced screener once they got into the room with clinicians. And that we were able to expand to, you know, identifying women who were at a higher risk for breast cancer, other types of cancer, and ultimately met those screening guidelines for genetic testing. With that, both identifying women who are at high risk, but also offering genetic testing, it dramatically changed not only our ability to have a more informed conversation with our patients, but how they felt about the quality of care that they received with us here at the clinic, and their future success with completing those screening protocols. Genetic testing is one of those things that patients have heard of, they know about, they're excited about, and at least in my experience, none of them expected to be able to do something like that at the Oklahoma City Indian Clinic. You know, they think my friends in private clinics or with private insurance have difficulty getting those tests done or finding somewhere where it can be done successfully. Again, I keep coming back to the pride that our patients have when they're like, I can't believe how good my care is becoming, especially as a woman receiving all of these extra services. That is one of those things that continues to empower us as providers to add more services, add more patients, grow our clinic overall, is seeing the success that we have, but also the patient perspective. I could spend a whole conversation specifically talking about the benefits that we had with genetic testing, but I think at a minimum, finding a way to do that hereditary risk sort of screening, even if you don't get all the way up to genetic testing, identifying your women who are at a high risk for breast cancer dramatically changes your ability to offer mammograms, to offer MRIs. It opens up the door for extra areas of funding, which I know for all of us in UIOs is a big aspect of what limits our ability to offer care. Find a way to build it into your system. Find a group to partner with, if it's Myriad or another company that's closer to you that you can develop a relationship with. For us, it cost us $0 to start, and over 90% of our patients paid nothing out of pocket to do it. So a big add for our clinic that has only continued to grow. Next slide, please. From there, the genetic testing led to improved outcomes for us. And I think this is just a great sort of informational look at what genetic testing looked like for us in that first year. So 97% of our patients was $0 out of pocket. We were able to test, essentially looking at this tree of testing, all of the patients that we captured are represented on the tree. The green leaves there, 150 women who were low risk and did not have genetic abnormalities. 9 women represented by those red leaves who were high risk because they had an identified genetic abnormality. And then on the orange leaves, those are our women who did not have genetic abnormalities, but did have a high risk negative. And interestingly, those high risk negatives are the women's where the women who we were able to have the most impactful changes on. That included catching several women with early cancers that had mammograms within the previous few months, were identified as being high risk. We were able to set them up for MRIs, and they captured early cancers that had been missed on mammogram, would not have been caught for at least another 9 to 12 months, and were identified as aggressive, potentially invasive cancers that we were able to capture and eliminate just by offering this service line. So a huge addition for us, definitely something that if you're looking at expanding service lines from an outpatient perspective, you don't feel comfortable with the prenatal perspective, this would be a big add for your women's program as well. In addition to that, go ahead and go to the next slide. After we did genetic screening for, next slide, please. After we genetic screening for hereditary cancers, we were able to add it to our prenatal testing as well. So this year, the big focus that we're looking at is improving our outcomes from a prenatal perspective. By adding in antenatal genetic testing, we're able to look for chromosomal abnormalities in our patients. We're able to kind of tell women as early as 10 weeks what the gender of their baby is, which again is one of those small things that people are very excited about and very excited to know that they can have completed here, typically for free. But we're also able to do carrier testing, which is looking at genetic testing for our mothers to identify some risk factors they may have that help to shape my workup as the pediatrician, both in the newborn and the later pediatric years, looking at, screening evaluations and other treatment modalities that we may need to offer both to mom for antenatal counseling and then for those kiddos. But This year, like I said, as we begin to look back at our obstetrical outcomes, the big focus that we are looking at is maternal morbidity and quality outcomes. And that for us is going to come through partnering with review committees. MMRCs or maternal morbidity review committees are something that probably already exists within your communities. Whether it's at a local level, a state level, or regional, I'm sure there are ones that you may be able to reach out to partner with, to help share data with. For us, we were able to expand our involvement locally within Oklahoma City, as well as partnering with larger groups. Part of that with NCUIH, who really helped to introduce us to some of the resources that helped us to partner with the Southern Plains Tribal Health Board, which is a regional group for us here in Oklahoma that represents Texas, Oklahoma, and Kansas. But again, I think the beginning is getting women in the door, focusing on women's service issues, expanding your service lines, and then gradually chipping away at all of those roadblocks that stand in the way of women receiving the highest quality of care. Our vision is to represent the national model. And so for us, we always are trying to strive for how can we improve the quality of care that we provide to our women here? How can we improve our outcomes? This year, we're really challenging ourselves to tackle those issues, to compare ourselves to other people locally, regionally, nationally, and to make sure that we're holding our own processes and our outcomes to that highest standard. I definitely think this is getting into that sort of higher level work. And for many of you, where you're at in your sort of expansion of women's services, this is sort of, that's not even where we're at yet. But I think looking at the trajectory, this is within 5 years. We went from, there was a nurse practitioner only doing limited prenatal care, some PAPs, starting to do colposcopy, to where we are now, a full colposcopy program. We have partnerships with local, physicians who can do diagnostic procedures. We're offering genetic testing. We're improving our cancer prevention, treatment outcomes. We're improving the success rates for our pregnancies, empowering women to have culturally competent care and keep their kiddos within the Indian health system, and to be proud of that. I can't echo enough how important that is to me, at least for my patients, that they come in the door and are proud that they receive their care here. They choose to come and see us. And I think that's a big driving force, at least for me, and how we're defining our program in the decisions that we make. And hopefully that's reflected by the results that we've had and kind of the conversations that we may hopefully have with you all as you continue to make progress going forward as well. Next slide, please. So I think many of you may also kind of be considering, I don't know sort of what would even go into that. What is my staffing analysis going to look like? How many people does it really take to do something like that well? This is a picture from last year of our team, our women's health team. But where we are now, we have 2 physician family OBs, as well as a women's health nurse practitioner. And then in addition to our providers, we have a nursing staff, which includes an RN case manager that we talked about earlier, or a clinical nurse manager, 4 LPNs. So not just one-to-one, but an additional LPN to kind of help with workflow and turnover. We have an integrated behavioral health clinician. So that is a medical family therapist who partners with us for all of our prenatal visits, who's able to come in and do a lot of counseling, not only on just sort of general pregnancy, but adverse sort of mental health aspects of care that can come up, that partner with our women to talk about domestic violence, substance use, depression, anxiety. That is a very big, important part of why I think our team is so successful. So again, there's so many small projects that are one line on a presentation like this that took a lot of thought and creativity to make work, but they paid dividends. A dental hygienist was another one. We partnered with the American Dental Association and the Academy of Pediatricians to do a project looking at outcomes data for pregnant women who were able to take good care of their teeth versus those that weren't, and then the later data of how that affected newborns and oral health in the pediatric setting. And that prompted us to sort of dedicate time, energy, and money into getting an integrated hygienist who is able to go in and see all of our pregnant patients, all of our pediatric kiddos when they come in, With all of the expanded service lines and adding more patients to the schedule each day, we had to kind of coordinate scheduling. We have prenatal educators who are able to partner with our patients on issues like lactation or sort of aches, pains, complaints that are normal to pregnancy, counseling them on what the delivery process may look like, helping them to coordinate tours of the hospital. And then, like we talked about already, adding on those additional service lines like non-invasive prenatal testing, the hereditary cancer screening, the colposcopy program, our ability to do mammogram on site, and all of the other service lines that we were able to expand based on grant funding that was supported by the success we had in our women's clinic. Next slide. For us, again, I think I'm taking a very high level view of what a UIO's women's program could look like, but that is kind of where we're at now. And again, this is a timeline. I'm entering my 6th year here. So in 5 years, we're now looking at expansion to a new location for our women's and children's clinic because we've gotten so big. We need to add another physician, probably another nurse practitioner, just based on the volume that we have. In addition to that, that new facility is hopefully going to give us an opportunity to increase our more invasive outpatient services, like offering those leaps and cones with an Indian health provider in-house, as opposed to having to refer them out. And then as we continue to grow, as we sort of see our footprint gradually take a bigger and bigger step at capturing those services for our Native women, delivery is something that we're sort of setting our sights on very excitedly, but also trying to make sure that we make the best decisions for ourselves financially as far as outcomes. It's a big part of why we really want to partner with groups like those MMRCs to identify what are our weak points now. We've had so much success, especially compared to where we were, but what is the highest standard? What are those levels of care that we need to be striving to achieve before we take those next steps? And as we create our future plans, that's how we look forward. So I sort of challenge each of you, your future plan may be anywhere from the very beginning of that milestone timeline that I've laid out all the way up to the end, but you fall on that timeline somewhere. Everybody kind of falls in some perspective. The question is, what's keeping you from moving up to the next stage in the timeline? You know, what's keeping you from dedicating some time, space, staffing to women's health issues, or expanding your women's health service line, or reaching out to me or another community resource to say, I want to do more for my women's clinic. I want to see this clinic grow successfully. What do we need to do next? You're obviously here, you're excited to hear kind of what we've been able to accomplish. But as we kind of move forward into more of the question and answer part of this discussion, hopefully you guys have been able to think about that and come with some great questions for me today. So next slide. And that is right where we're at. So I didn't want to take up all of our time. I wanted to kind of give you the high level picture of what we were able to accomplish and how we got there. Like I said, really each of those slides, I could spend 20 or 30 minutes just talking to you about what our pitfalls were, what were the things that we were challenged by, or the successes that we had. But I wanted to make sure that you all had a chance to ask questions specific to where you're at in your women's clinic, and the things that are most pressing for you.
All right. Thank you, Dr. Freeman. That was so informative. So, yeah, I see a lot of familiar names in the room. I'm sure some of you have questions for Dr. Freeman, so please raise your hand and unmute yourself or ask your question in the chat if you're not comfortable speaking to the room. But yeah, we'll just pause here for questions.
I'd like to ask a question, if I may. Leticia, hello. Yes, Leticia from San Diego American Indian Health Center. Did you have to rely on grants at any point to help with the expansion, or were you able to fund mostly through the insurance and Medicaid?
Yeah, I think that's a great question, especially as you look at the financial feasibility of how you could see similar growth in your clinic. From the outpatient perspective, all of that growth was completed within our sort of internal staffing analysis, and looking at the potential for reimbursement and outcomes data. So like I said, for us, the largest aspect of our prenatal care are our women here, at least in Oklahoma, are mostly eligible for Sooner Care, which is our internal Medicaid. And that is a sort of flat rate service that we receive here, which I know is probably similar to what you all have organized with your particular state funders. In the delivery setting, we were able to, again, acquire even more reimbursement for the services that we're offering in the inpatient setting. Where we relied on grant funding for the most part was expansion of ancillary services. One of the big grants that we got early on was with the American Cancer Society, who was able to fund us obtaining a mammogram machine in-house, a brand new machine with brand new software packages, which was a big switch from where we had been before. You know, in that pre-2015 to 2018 stage, we were partnering with the University Hospital here in Oklahoma City, and they had a mammogram sort of bus that would show up at the clinic, and we would have women kind of schedule a time to line up and go onto the bus and get a mammogram, and they would follow up all of those things externally. But as you might imagine, you know, sometimes women are in the building and they can only do things right then, and coming back for a mammogram bus is not the best way to see those things happen. So that grant was a big expansion in our service line early on. Some of our other smaller partnerships, like I said, the American Dental and Pediatrics sort of project that we worked on, there was some grant funding there, mostly that just helped us to acquire that data, recognize the need, and really define for our senior leadership, hey, this is directly tied to outcomes. This is something we need to invest some of our time and money in. And once, at least for us, you can make that clear correlation, it made it a lot easier to invest in those positions. Currently, we're utilizing some grant funding for focus on STI screening, which is obviously a big aspect of women's healthcare and prenatal outcomes. And then also our partnerships for the maternal morbidity review committees. But again, the actual clinic itself, you know, hiring me on, having a nurse practitioner, hiring that additional MD, none of those salaries were grant funded positions. That was all directly tied to sort of reimbursement rates and the productivity of our women's health clinic in general. Any other questions, or is there anything else that you wanted to ask from San Diego?
Hi,
Thank you.
thank you. My name is Kimberly Blackhorse. I am a board member of Denver Indian Health and Family Services. I was wondering if you received any funding related to Title V from your state, and or if there are certain concessions through your state that you had to abide by, and it was just probably not worth the work to do so.
Yeah, so in particular, no, we didn't work directly for that Title V funding. There weren't concessions that we made in the outcomes that we were pursuing or services that we offered. Definitely when it came to a reimbursement perspective, you know, that some of that I think is outside of the scope of what I was always in the conversations for. So I certainly don't want to completely rule that out, but no, it wasn't how we defined where we wanted to go. We started with the patients first and the quality outcomes first. That's how we made our decisions about what service lines we wanted to see succeed. And then from there, we chased funding wherever we needed to help kind of accomplish those tasks. For the most part, like I said, our primary funding was Medicaid and then Blue Cross Blue Shield. So I guess in short, no, I don't think it was something that we had to have concessions for to kind of meet those Title V aspects of care here in the state of Oklahoma, at least.
Thank you. That's very helpful. I was wondering if there were any, could you describe your relationship with the tribes in the area and their tribal citizens who receive healthcare through your services? How are you working with the tribal governments within Oklahoma or in the surrounding area to, if there are any, if you could discuss the shared data access that they would like, or anything that you have come up related to sharing data or creating MOUs or data sharing agreements? How has that process gone?
Yeah, so I'm going to kind of tackle that question in a couple of different parts, but I think the first big question there is how well do we incorporate with tribal health and leadership? And then the next big one was that sort of data sharing component. So our clinic in the Oklahoma area, there are a lot of different tribes that are represented at our clinic. I always forget the number, but over 200 different tribes are represented in the care population that we have here. Within an hour or two of where our clinic is, there are several different regions of tribal lands or tribal governments, including many of them having their own tribal clinics that patients seek care at, in addition to coming to see us here. So we have a lot of interaction with tribal governments and tribal health in the surrounding area, including IHS facilities as well from a more federal perspective. Our CEO, fortunately, is very good at maintaining those relationships and communicating at all levels within sort of tribal health and Indian health, but especially some of those bigger partnerships that we have. Chickasaw Nation is one that we partner. I say partner with. They're the closest major Indian health facility to us is at the Chickasaw Nation in Ada, Oklahoma. That's the one that's about an hour and a half from where we are now. So many of our processes, especially for our uninsured IHS only patients, we sort of develop in tandem with the resources that they have available there. So that I think is one of our larger partnerships, but there's several very robust and well-developed tribal governments in the state of Oklahoma that comprise a big component of our patient population here. So definitely, I think maintaining some of those agreements is really important, just to make sure that you understand what services you're each offering. And to kind of get to the second part of that tribal question of how do they utilize our services, we have, specifically looking at women's health services, we have women who only come here for those elements of the women's health sort of expanded service lines that we have in-house. So mammograms, for example, we'll have women from outside tribal clinics who will come here just for their mammograms, or they may come here just to get a DEXA scan done to rule out, their fracture risk related to osteopenia, osteoporosis. We also have women who are able to sort of get referred over here for prenatal care to expand their ability to get either prenatal care within an Indian health setting, or if they're eligible for insurance, they transfer here to get their prenatal care and then go back to their tribal clinics afterwards. Again, because we're all at different stages of developing that women's lines perspective of service lines. So the biggest thing I think is maintaining those partnerships. The last thing is data sharing. You asked about that. I think it's a very important topic for tribal health, Indian health, urban Indian organizations, is that element of data and the importance of sovereignty of data, of patient information. there's not a lot of data sharing that we do right now. Again, because that sovereignty of that tribal information and of those tribal members is, of the utmost importance. So at least in the capacity that I'm involved with it right now, I would say very little of that is true, like identifiable data sharing. But we do work in tandem with one another to look at sort of grouped outcomes and demographic data and trending to sort of identify where are some of our weak points within our women's systems, especially as we're kind of increasing our footprint in the MMRCs in our current stage. There's going to be more recognition of some of those group trending that I think is going to continue to grow for us going forward.
Thank
I
you.
answered several questions there, so hopefully I got what you're asking.
Absolutely. Thank you for sharing, and thank you for sharing for what you do at your clinic. It is very helpful, and it sounds like you all are tackling wonderful opportunities there.
Angela, so you're unmuted. You wanna go ahead? Maybe not.
Any other questions? I know sometimes people are nervous to comment in a big setting, so if you want to throw stuff into the chat, I can answer from there too.
Seems that Angel was trying to come off mute. He's having trouble with his mic, and then Kimberly had an additional question in the chat.
Yeah, so looking to expand, so just kind of reading off Kimberly's questions, are we looking to expand maternal health team to include access if patients chose to use it of indigenous doulas, traditional practitioners, or nutrition consultation from an RDN and lactation consultant? So I failed to mention, we have registered dietitians and a pretty robust health promotion and disease prevention program within our clinic here at the Oklahoma City Indian Clinic that includes physical trainers, a full wellness team, dietitians specifically dedicated to sort of prenatal and women's health. But for us on the pink team, we also have a pediatric dietitian who's able to tackle those elements of diet from that perspective as well. I certainly think that's a big part of looking at our outcomes data for pregnancy outcomes. Gestational diabetes is very common, unfortunately, in our population, and being able to affect change in lifestyle and diet for women is a big part of how we see successful outcomes. Lactation consultants, again, a very important part of especially that newborn and early pediatric outcome, but also for our postpartum women. Breastfeeding is very clearly tied to some great outcomes data for postpartum women as well. We fortunately were able to get 2 of our LPNs as certified lactation consultants. That was something that they chose to champion. Both my LPN and the Dr. Francis personal LPN are both certified lactation consultants. So that's something that we can offer to patients real time as they come to see us here in the clinic. Definitely, I think, an important aspect of care. We don't have doulas yet. We definitely do. Dr. France and I both, being family OBs, we lean towards some more holistic methods of sort of evaluation and treatment. And we have such robust wraparound services here that we've talked about doulas. It's not something that we've pursued yet, but we definitely have discussed it several times, trying to kind of identify what that doula model might look like for us. But with our prenatal educators, with lactation and dietetics and lifestyle and all of those things built into our current program, we haven't made that leap yet. It doesn't mean we won't. We just haven't gotten there yet. The other aspect is sort of those traditional aspects of maternal health counseling, and then sort of those post-birthing sort of cultural practices. That's a part of our prenatal screening early on. At those first visits, we sort of ask about religious aspects of their culture that might impact our decision making during the prenatal process and delivery, and also the cultural aspects of what may be specific to them and their tribe. Some specific things like what they would like to do or see be done with the placenta after delivery, or what sort of fetal tissue after, like cord samples and things like that. Some tribes have very particular cultural expectations for those things. Similarly, the first voice in a room that's supposed to speak, or instances like that that are very important to the cultural aspects of care. We try to address those early on, and make sure that our community partners, the labor nurses, or other practitioners that might be involved in care, know that as soon as our patients are admitted at the hospital. Looking at Angel's question, can we share a little bit about what are the Native American birthing rituals that the clinic is supporting or looking to support? So, like I said, it's something that we definitely try to explore with each of our patients. As you all know, in an urban Indian clinic, there's a very broad range of the sort of cultural awareness and adherence to some of those traditional practices that some of our patients have, all the way to some of our women who unfortunately may not know much about their cultural or their sort of indigenous heritage. And so those are things we explore on a case-by-case basis. We try to meet as many or all of those expectations as we can. Few and far between have there really been any real limitations in our partnerships with the community hospital. Ritual use of smoke and things, that some of that is limited in the hospital, but for the most part, I think we've really been able to meet our patients where they are and try to give them the best sort of cultural experience based on their expectations for birth and postpartum care. At least it's something that we strive to do, and I haven't had any of my patients be frustrated with the outcomes yet, I guess I would say. Thank you, Angel. Looking at Wendy's question, she said, if we had a wish list of how Medicare and Medicaid, how it could help expanding maternal health services, what would be number one on that list? I'll say for us in the state of Oklahoma, and I think this is really the trend nationally, the move to expand that fourth trimester or that postpartum coverage out to a full year postpartum was hands down one of the biggest things for us. I think to say that postpartum care ends at 2 months is very short-sighted. As a family doc, I have the luxury of seeing my postpartum women a number of times in that first year, because the babies come in at 2 months and 4 and 6 and 9 and 12. So every couple of months I get to check back in with my postpartum women to say, are you still breastfeeding? Do we need to reassess what your kind of contraceptive goals are? I get to assess what their mood looks like. Domestic violence is unfortunately another very real risk for women across the nation, and somewhat higher amongst our Native women, as many of you know. Getting to see women throughout that whole year and the expansion of care, that to me was one of the biggest changes. Beyond that, some of the higher tier diagnostic testing and screening, if it was more accessible, getting the diagnostic excisional biopsies for abnormal breasts, or a more robust availability of Indian health funding from the federal level for like leaps and cones within our setting, I think that would be another big game changer for us. I think it's something that's kind of right around the corner. I know that our partners, especially NCUIH, are really helping to kind of fight for funding of some of those areas. From a women's health perspective, I think that would be the other big thing. The last one it's not necessarily unique to women, but definitely I think is a big factor. And that is the wraparound social services, food insecurity, domestic violence, as I mentioned, housing insecurity are big aspects that define the outcomes of care, especially in pregnancy, especially in the postpartum setting and for our newborns and early infants. That's another area that I would love to see funding increase for and accessibility improve to see better outcomes if I was going to name something in particular that we don't have yet. Thank you so much, you guys. Any other questions?
And if you, while you're thinking of those questions, if you have any additional ones, we do have a little more time, but we will also be sending out, of course, a thank you email. And if you have any additional questions, feel free to, reach out to myself or Dr. Freeman. Letitia.
Hi, I do have another question. When with your expansion, of course, you needed to grow your team. How difficult or challenging was it, or not, to recruit the providers and other staff to be part of your program? Because for us here in San Diego, there's a lot of competition, and so we have a very hard time being able to find like the qualified staff that are also culturally competent and able to serve our patient population.
Yeah, I think I can't overstate enough how important it was that I was passionate about seeing the service line succeed and the role that I wanted to play in women's health. I was born at the Chickasaw Nation down in Ada. I grew up going to receive my care through Indian Health really most of my life. I knew that I wanted to be able to come back and really see and affect change for Indian health here in Oklahoma City, and women's health being the biggest passion that I have. I felt like there was a lot of low hanging fruit to see our Indigenous women receive better care here. That definitely is going to be one of those struggles to see a program really expand quickly, successfully, long term. You're hitting the nail on the head there, that you have to find somebody who is passionate about it, especially at the beginning of that expansion. Like I said, there was a lot of sleepless nights doing deliveries, a lot of vacations that could not happen because I didn't want to leave town and see my patients kind of be left with whoever was on call at a hospital maybe stepping in to fulfill some of those services on my behalf. Both the cultural competency perspective and having someone who's interested in really championing that change is something that you're going to have to weed through a lot of applicants and really identify someone who has that heart for women and a passion to see that change happen in your clinic. That definitely is going to be one of the hardest parts at the beginning, I think. However, I think if you can find someone who has some of that interest or some of that passion, even if you're only able to implement some of the aspects of this change, I think the prenatal care definitely that's a leap that you have to find the right person to implement that. But the outpatient aspects of care, when we think about improving cervical cancer screening, looking at the genetic testing model, doing colposcopies, and improving just the awareness that women have of preventative issues, that is something I think you'll be able to recruit hopefully very easily and successfully within your native community there in San Diego or wherever any of you are based. But the leap to full prenatal services, not only finding somebody who's willing and able to kind of meet that need within your clinic, but also able to maintain those partnerships in the community. That's the other kind of big step, is they have to have privileges at a local hospital and be able to take your patients there successfully, and maintain good outcomes data there so that they can keep bringing those patients. Depending on the hospital and depending on your community and how enlightened or not they are, sometimes they may see, you bringing this new population of Indian clinic women to their hospital as not something that they're interested in, and that sort of discrimination, unfortunately, is out there. It's here in Oklahoma. I'm sure it's in your communities too. And so having someone who can navigate some of that with hospital leadership is another aspect that you're going to have to be able to recruit as well.
Thank you for that. It does make me think about, us having to strengthen maybe the collaboration that we have with the UCSD medical school. And they do have a strong Native organization there for the Native students going to medical school. So yeah, thank you for that.
So another question from Courtney. Oh, sorry. Another question from Courtney. Are there any policies that can be proposed or improved to help urban maternal health outcomes? Is maternal mortality an issue in our community or state among the Indigenous population? Yeah, so definitely there are policies that can be proposed. This was something, there's a large collaborative agreement that's actually happening right now with groups like NCUIH, with the American Heart Association, and with some of the regional and state level quality-based organizations that are trying to implement change for minority women in general, but specifically focused on Indigenous populations. There certainly is a disparity in the accessibility to healthcare, and as a direct correlation to that, outcomes for our Indigenous women. So I think it's 100% something that we as a community need to sort of band together and champion to see our legislators and those people who help to advocate for our Native women see affect change in our kind of local, state, and federal legislation. It's definitely something that we need to champion. I know, again, I kind of mentioned at the end here, I think it's something that we're starting to focus on more. At the White House level, they're sort of setting an objective for us to be more mindful of maternal morbidity outcomes, especially amongst minority populations. And so I'm excited to see that sort of language is coming from the executive branch down and sort of forcing the states to take Indigenous women's health more seriously. So now is definitely the time where there's some momentum for us to really jump on board and see some good outcomes.
Thank you, Dr. Freeman. Any additional questions? They've all been great, by the way.
Just if anyone's kind of thinking of a question, or before we wrap up, I want to mention, if any of you are at a place in your urban clinic where you're like, I want to make this jump, but there's some more things that I need to hash out at a process level, or I need to kind of think through this, and then I want to flesh out some details. I encourage you to kind of reach out to Maddie or myself. I'm very passionate about our Native women. I want to see these outcomes. This isn't something I just want to be great here. I want to kind of set a standard and help everyone else meet that same outcome wherever you are, at whatever level you're capable of it. So I'm more than happy to kind of help participate in that as you guys go through decision making moving forward.
Absolutely. Thank you for that reminder, Dr. Freeman. We just, Courtney, for your answer to this follow-up, you will get access to the recording, and thank you for your offer. Always appreciated for the support. All right, well, I think we can go ahead and move on to just the last couple things that we have for this presentation. Oh gosh. Okay. Yeah, so just some closing reminders. Thank you so much for joining us. I know we're going a little longer than what's usual, so thanks for staying on for those of you who were able to. Again, this recording will be sent out. We appreciate any feedback that you would like to provide about your experience today. On the survey, you can just use the Qualtrics or the QR code right there. We will also place that link. Oh, that's right there in the chat box. Again, if you have any questions, please email myself, Aaliyah, or Dr. Freeman. If you could put your email in the chat, that'd be great as well. And next slide. So NCUIH, we also have a lot of upcoming events that we would love for all of you to attend. And these events include Navigating the Crisis in the Role of 988. Tomorrow's July 11th and July 16th, there will be IPC practices and addressing wound care. And then on the 23rd of July, it's Clinic to Community, utilizing the 340B program to improve HIV care for UIOs. That will also be 340B applies to all clinics as well. So next slide. Just as a reminder, the Technical Assistance and Research Center provides individualized technical assistance, training, and support to our member UIOs, such as community and staff training, consultation on research and evaluation, program planning and implementation, documenting best practices, grant application review, local partnership development, locating unarchivable data to support community work, and policies, procedures, and operational needs. Next slide. So thank you very much. Any feedback you would like to provide about your webinar experience, please do not hesitate to complete our session survey. And thank you again for attending, and have a wonderful rest of your day.